So,
Fine.
when you have a patient in the ICU who presents with fever, leukocytosis, shock, and infiltrates, there is sometimes a diagnostic dilemma, not in all patients, whether it is an infection or a sterile inflammation. Similarly, when you have a patient of sepsis and you delay the initiation of antibiotics, you're causing more harm. Unnecessary initiation of antibiotics again can drive up your MDR prevalence, C difficile, toxicity, and of course increase the costs. So there is a treatment dilemma as well. Then can we safely de-escalate or stop antibiotics at 40 to 72 hours? So this is where biomarkers matter in the ICU. So when you use these biomarkers, you should bring them into practice only if doing a biomarker level is going to result in a change in treatment or changing the decision of what you've initially done. Never use an isolated biomarker value to decide about the treatment plan. It should always be a serial trend. As we go ahead, we'll understand this. So we will understand how procalcitonin and CRP are produced, how to interpret false positives, false negatives, and how to correlate these clinically. Now, remember that a biomarker is an host inflammatory response. It is not a, a diagnosis. It gives you a signal. So, when you are now, this host inflammatory response can be triggered because of bacterial infection, because of injury, because of inflammation. What will this do? This will cause a host response and release of cytokines. It is because of this host response in the acute phase which causes these biomarkers to rise, your procalcitonin and your CRP. So, when you clinically correlate this, with the clinical presentation, the cultures, the imaging, that is when these biomarkers actually give you a signal. So never use them isolated. Now, how is procalcitonin produced? It is a precursor of calcitonin, mainly produced from the thyroid C cells. Normally, in a healthy state, it is very low. So, when there is a bacterial infection or sepsis, the extra thyroid tissues produce procalcitonin under the endotoxin and cytokine stimulation. Similarly, in a viral infection, because of the interferon gamma response, the procalcitonin production is suppressed. So that is why in our viral infections, we often see that the procalcitonin values are negative. Then CRP is produced, synthesized by hepatocytes. It is driven mainly by IL-6, IL-1, and TNF pathways. The weakness of CRP is that it is a non-specific marker of inflammation. It is widely available, economic, sensitive, so it is very often used. But you should always know how to interpret the values and correlate it clinically and never use it as a isolated blind marker. Now, you've done the tests. What timing you send these tests and what values you obtain also matter. Now, procalcitonin, if you look at, rises at 6 to 12 hours, peaks at 24 hours. Its half life is about 20 to 24 hours. And once there is response to treatment, whether antibiotics or whatever the underlying pathology of your procalcitonin high is, it starts to fall by 50% per day, which tells you that there is a response to your treatment. On the other hand, when you look at CRP, it rises after the inflammatory stimulus, often peaks at 24 to 48 hours, has a half life of about 19 hours. And this basically tells you the ongoing inflammatory process. So, when you have a value of procalcitonin in your hand, you have a patient's report, how do you interpret it? A value of less than zero point 0.1 tells you that the bacterial infection is unlikely in a low risk setting. Similarly, a value of more than zero point 0.5 supports systemic bacterial inflammation, but treat if the clinical syndrome fits. Like I said, do not use these values isolated or just use them as a guide for your treatment. In septic shock, never delay antibiotics because of a procalcitonin being low. Because a high procalcitonin does not always mean that it is only bacterial infection. It can be falsely positive or high in cases of major surgery, trauma, burns patients, severe shock, pancreatitis, renal dysfunction, patients with cirrhosis, medullary thyroid or neuroendocrine tumors. So never isolated depend upon one value. Then, similarly, a falsely negative PCT does not always rule out that your patient does not have infection. Because, like we just discussed about the time when these start rising, if you've done the sampling too early, then at that time also you can receive a report which is showing you a low procalcitonin. A localized infection like an abscess, empyema, or a wound infection may not have a positive procalcitonin report, a low bacterial burden, then a patient who's immunosuppressed or who's received prior antibiotics. Patients with viral infections, atypical fungal or inflammatory lung disease can all have a low PCT. Does not mean that this is ruled out infection and you can just simply discard the possibility. Like procalcitonin, CRP also has a range. So less than 10 is usually normal. 40 to 200, can you imagine such a wide range? Tells you about active inflammation, where bacterial
Oh,
infection can be possible. And more
good
than
evening. Good
200
evening.
is severe bacterial infection,
हाँ मैं घर पहुंच गया हूँ.
can also be seen in burns or major inflammation. So remember, it's a marker of inflammatory process. Now, CRP, like I said, can rise in any acute inflammatory process, in autoimmune diseases, inflammatory bowel disease, osteomyelitis. It can decrease or be falsely low because it's produced from the hepatocytes in severe liver failure, reduced hepatic synthetic capacity. So it's a non-specific marker of inflammation and it is influenced by genetics, age, lifestyle, even affected by stress and environmental factors. So remember, CRP is a trend marker. Falling CRP supports recovery and a rising CRP after 48 to 72 hours should trigger source search. Do not blindly escalate your treatment just based on the CRP value. Now, when you compare the two, the procalcitonin and CRP, we know that procalcitonin is from the extrathyroid tissue and CRP is from hepatocytes. Procalcitonin rises early within the first day, and CRP is often after 24 to 48 hours. Procalcitonin is more bacterial weighted, but it's not a perfect marker, and CRP is more sensitive for inflammation, but it lacks specificity. Procalcitonin would support antibiotic discontinuation or de escalation, whereas CRP tells you response trend and inflammation monitoring. There have been a lot of research on these markers. One of the older diagnostic studies showed strong procalcitonin performance when it was compared with CRP, IL-6, and lactate. As you can see, sensitivity was almost 89% and specificity of 94%. So, how do you integrate this in your clinical practice? You have a patient who is admitted with clinically stable CAP, and you obtain the procalcitonin values, say, every 1 or 2 days. So, you have to look at the procalcitonin trend, whether it's stable or it's rising. If it's stable, you can consider de escalation. If it's rising, then you have to think of alternative cause. If it is declining, if the level is less than 0.25, then you discontinue antibiotics under the following possibilities. One, there could be an alternative diagnosis, there could be a probable viral pneumonia, or there could be a clinical improvement in your patient with CAP after several days of therapy. However, if the procalcitonin value is not less than 0.25 and the peak is more than 5 nanogram per ml, but this is after, say, 5 to 10 days of treatment, it is, and when you look at the value, it is more than 80% decline from the peak value, which was initially at the onset of your treatment 5 to 10 days ago. Then again, in this scenario, you can discontinue the antibiotic for your patient. However, if the levels are still high, you continue antibiotics and you do serial trends to see the response to your treatment. So when should you order PCT or CRP? When there is an unclear ICU fever, when there is a low or intermediate probability of infection, culture negative sepsis in improving, and monitoring response after source control. Avoid routine misuse. Do not use it as a daily ICU panel without any decision, treating only the number, not looking at the patient profile, extending antibiotic therapy because your CRP is remaining high, or escalating antibiotics because your PCT is rising. Don't do that. So, you should always have your clinical clues in mind. Look at the patient, compare it, look at the cultures, look at everything together, and then use these as an addition rather than just as an isolated marker to treat, escalate, or rather de escalate your treatment. Now, this was recently published in 2025, an ADAPT-Sepsis trial, which was conducted in 41 UK ICUs on 2,760 adults with suspected sepsis who were randomized to PCT guided, CRP guided, or usual care of antibiotic duration. And what they saw, the key result was that PCT guidance reduced overall antibiotic use by about 10% versus the usual care, and CRP guidance did not show the same effect. So, where do you position these according to the latest Surviving Sepsis campaign 2026? Remember, sepsis is a clinical diagnosis. Do not rule in or rule out based on a single biomarker value. Do not use PCT to decide initiation in possible or probable sepsis or septic shock. For stopping antibiotics, yes, PCT plus clinical evaluation may help in discontinuation when duration is unclear or source control is adequate. So, this is very important to remember. So, the final take home message for these biomarkers is that PCT and CRP are host response signals, not standalone infection tests. PCT is more bacterial weighted, CRP is more inflammation weighted. Single values are weak, serial trends are stronger. Do not withhold antibiotics in septic shock or severe infection because PCT is low. Best practices to support de escalation or discontinuation at 48 to 72 hours when the patient is improving. After the biomarkers, let's look at the antibiotic classes in respiratory and ICU practice. Remember, adequate early coverage is the key, then active narrowing at 48 to 72 hours. So, we are going to look at antibiotics that are used in community acquired pneumonia, severe CAP, APAP infections, MRSA, pseudomonas, MDR pathogens. Then we look at the doses and the renal and liver dose modifications. Sorry. So, when you have a patient in the ICU and when you're thinking of the initiating antibiotics, you must always keep certain principles in mind. That is, what is the source of infection? Whether the infection is community acquired or hospital acquired. What organisms are you thinking? What organisms should you cover based on the presentation? How sick or critically ill is your patient? If lung is the source, is the drug well penetrated in the lung? And when you can narrow. You should always have these basic things in mind before you think of antibiotics. There are various antibiotics that we commonly use in respiratory practice, and this can be remembered under 7 practical buckets. We have the beta-lactams, the atypical cover, MRSA drug, anti-pseudomonal drugs, MDR gram-negative drugs, anaerobic aspiration drugs, and special respiratory drugs. I'm sorry. So, amongst the beta lactams, we have the penicillins, that is the penicillin G, the aminopenicillins, the amoxicillin and ampicillin, then beta lactam inhibitors like the co-amoxiclav, ampicillin, piperacillin, tazobactam, and anti-staphylococcal, that is neficillin, cloaxicillin, and flucloxacillin. Then the other group of beta lactams we have is the cephalosporins. We all know that cephalosporins are in various generations. Among the second generation, cefuroxime, third generation, ceftriaxone. Anti-pseudomonal cephalosporins are your ceftazidime and cefepime. And anti-MRSA are ceftaroline and ceftobiprole. Remember, ceftriaxone and ceftaroline do not have anti-pseudomonal activity. Then the carbapenems, monobactams, and newer BLIs. We have amongst the carbapenems, we commonly use meropenem, doripenem. Now, ertapenem is useful for your ESBL, but remember it does not have activity against Pseudomonas and Acinetobacter. Then amongst the monobactams, we have Aztreonam. And in the new beta-lactam inhibitor agent, we have ceftazidime avibactam, ceftalozone tazobactam, Aztreonam avibactam, then meropenem, viborbactam, and imipenem rilebactam, which are not available in our country. Then for the atypical, we have macrolides, which we commonly use azithro, clarithromycin, nafithromycin. Tetracyclines are very widely used, doxycycline, minocycline, and TG-cycline. Respiratory fluoroquinolones, we have levo and moxifloxacin. And ciprofloxacin among the fluoroquinolones mainly has only anti-pseudomonal activity. Now for the gram positives, whether it's your MSSA, MRSA, and VRE, we have glycopeptides, Vanco and ticoplanin, oxazolin diones, linezolate, tadazolate is also available now. Then anti-MRSA beta-lactam, that is ceftaroline and ceftobiprole, and daptomycin, which is a very good gram-positive cover for bacteremia and endocarditis. Do not give it in your lung infections because it is inactivated by the lung surfactant. Then amongst the MDR gram-negative cover, aminoglycosides, amikacin, these days very rarely used, majorly because of the nephrotoxicity profile. Tobramycin, still used in respiratory practice as a nebulized agent for Pseudomonas. Polymyxin, we have colistin and polymyxin B. So for MDR, like Acinetobacter, we have high-dose sulbactam, durlobactam, as well as ceftriaxone. And for specific organisms like Stenotrophomonas, Pneumocystis jirovecii, Nocardia, anaerobes, we have trimethoprim, sulfamethoxazole, metronidazole, clindamycin, and TG-cycline. So once you've heard of all the names of these antibiotics, we understand that they work as they have a basic mechanism of action. So there is cell wall inhibition by beta-lactams and vancomycin, protein synthesis inhibition when they act on the 50S ribosomal unit. It's the macrolides and linezolates, 30S by aminoglycosides and tetracyclines. Then the DNA and RNA inhibition by fluoroquinolones and rifampicin, and membrane disruption by polymyxins and daptomycin. So let's look at a case now. This is a 52-year-old female who presented with fever, cough, and shortness of breath for 3 days. This is her X-ray on presentation, was hypoxic in type 1 respiratory failure requiring mechanical ventilatory support, hypotensive on vasopressor support, with TLC's neutrophilic leukocytosis. Recently diagnosed diabetic, no other comorbidities, admitted to the emergency department with this X-ray showing you a bilateral pneumonia. So this is basically a typical community acquired case that would present to you in the hospital, and the typical organisms that you should always keep in mind before deciding your empiric therapy: Streptococcus pneumoniae, Haemophilus, and Moraxella catarrhalis. Remember, atypicals should always be covered. That is your Mycoplasma pneumoniae, Chlamydophila pneumoniae, Chlamydia psittaci, and Legionella. So when you have a typical community-acquired pneumonia case like this, what would be your antibiotic of choice? So you start with a ceftriaxone 2 gram intravenous once a day, along with doxycycline. Now these days, of course, for an atypical cover, macrolides and respiratory fluoroquinolones are still very widely used. But macrolides have shown increasing resistance post-COVID, especially in Mycoplasma, which is a very common atypical organism. So the use of doxycycline has become more and more these days. Again, in respiratory fluoroquinolones, we want to preserve them because of the prevalence of tuberculosis in our country. So you do not want to use respiratory fluoroquinolones for a CAP case. So that is why ceftriaxone and doxycycline becomes a good empiric choice. Then for a severe community-acquired pneumonia, a patient in shock requiring intubation, again, your beta-lactam backbone plus a macrolide cover remains. You add a linezolate cover if there is an MRSA risk, a necrotizing pneumonia, or a patient has had a recent influenza infection. Necrotizing severe CAP in a patient with diabetic or who's been an alcoholic. Remember, you have to have three possibilities in mind. You have to have an MRSA cover, a hypervirulent Klebsiella could be the possibility, and in certain areas, there can be a possibility of miliodosis also in such a profile. So for MRSA, you give linezolate. For Klebsiella, you cover with meropenem. And based on the local epidemiology, where miliodosis is a possibility, you give a cover with ceftazidime. Then for viral positive pneumonia or a patient who is an RT-PCR positive, remember you should start your antivirals early. In patients who have a high suspicion, start them on oseltamivir. Treat a severely hospitalized influenza even if the presentation is delayed. For COVID, we follow the COVID protocol. And even in a case of viral pneumonia, give a start an empiric antibiotic cover because of the possibility of bacterial co-infection. You can stop the antibiotic cover at 48 to 72 hours if the patient is stable, cultures are negative, and there is no bacterial evidence. Now, when do you cover Pseudomonas in CAP? When there is a prior Pseudomonas history, when a patient has a structural lung disease or has bronchiectasis, recent IV antibiotics, or repeated use of antibiotics in the past. So remember what must not be missed in severe CAP. You have the beta-lactam backbone, you give an atypical coverage, risk-based MRSA and Pseudomonas cover, and you review your antibiotics at 48 to 72 hours. Now, we often do PCR and biofire tests for our patients, even cultures. They do have pitfalls. So, you need to understand them and clinically correlate before just jumping onto the report and starting an antibiotic for your patient. For example, a patient with community acquired pneumonia and has an early sputum biofire showing you Acinetobacter, and you started the patient on colistin. Remember, this is a community acquired pneumonia. So, there is a possibility of colonization. You cannot disregard that. Just don't jump onto treating the biofire report. Similarly, a biofire Klebsiella NDM and patient was put on ceftazidime, avibactam, and aztreonam. Now, you may miss pneumococcus typicals if community syndrome, and ceftazidime has a weak gram-positive coverage. So do not just look at the report, pick up an antibiotic and start it in your patient. Then an ET aspirate MRSA, daptomycin was added. I just told you daptomycin is inactivated by the alveolar surfactant. It is not a good drug for your lungs. Then ET aspirate shows you Candida. Candida is usually an airway colonizer, and you should not be treating it with fluconazole. Then let's look at another case. We just discussed a community acquired pneumonia. Now, this was a patient who was admitted 2 weeks back with a right MCA infarct, suddenly becomes hypoxic, is desaturating in respiratory distress, now requiring mechanical ventilation, is hypotensive on vasopressor support. You do a chest x-ray and has a right lower lobe consolidation. So, very typical case of an hospital acquired pneumonia. Now, when you are considering treatment for an hospital acquired pneumonia, remember you need to cover Acinetobacter, Klebsiella, Pseudomonas, and E. coli, because majority of the Indian tertiary care ICUs have a gram-negative prevalence, almost 80 to 90%. So your empiric principles should be that you should send a good respiratory sample and blood cultures before antibiotics, but please do not delay your antibiotic therapy just to send the samples. Cover gram-negatives, including Pseudomonas, based on the your hospital antibiogram. MRSA coverage where risk factors or in high unit prevalence. So, what would an empiric regimen with for a HAP-VAP include? So you have to cover a gram-negative bacteria along with Pseudomonas. So drug of choice would be cefepime or piperacillin tazobactam, ceftazidime or meropenem. MRSA coverage with vancomycin, linezolid or teicoplanin, where the risk of MRSA is high or your antibiogram or the typical unit has high prevalence. Anaerobic coverage when there is an aspiration complication, empyema or abscess, and your typical choice should be piperacillin tazobactam, carbapenem or ampicillin. For MDR drugs, MDR bugs, it should always be culture and AST driven. We have the new BLIs like the ceftazidime avibactam. We have polymyxins, cefderichol, but it should always be culture and AST driven. Then you've tested for gene resistance and you have your patient having ESBL or enterobacterial. So you have to think of meropenem, imipenem as the drug of choice. Ertapenem only if the patient is stable. Like I told you, there is no Pseudomonas or Acinetobacter coverage. For AMC producing organisms, cefepime if they're susceptible, carbapenem if the severity is more, or ESBL co-risk. KPC producing organisms, ceftazidime avibactam is a good choice. There is also meropenem and beborbactam and imipenem relebactam. Then for OXA48, ceftazidime avibactam is often active. And for MBL CRE, aztreonam avibactam or cefderichol strategies. We often use polymyxin B a lot, even in this class of patients who are showing these sort of resistance patterns. But these days, it is advised and recommended that you should use polymyxin sparing therapies so as to prevent more and more occurrence of resistance. Then for Pseudomonas, which is a susceptible Pseudomonas, one optimized anti-pseudomonal beta-lactam is enough. Extended infusion if your patient has severe infection. For difficult to treat Pseudomonas, ceftazidime, avibactam, and polymyxin remain the drugs of choice. There is also ceftriaxone, imipenem, relebactam, ceftalazone, tazobactam, but it all depends upon the antibiotic susceptibility testing. Now, there is also carbapenem resistant Acinetobacter, and sulbactam containing strategy is the preferred uh, therapy of choice. But more and more resistance in the Indian setups has been seen with sulbactam. Still, the therapy of choice remains with high dose ampi-sulbactam and polymyxin B, or minocycline, or high dose TG-cycline, or ceftriaxone, but it should be guided by your antibiotic susceptibility testing. Now your patient got better, it's been 2 weeks, and now suddenly, he develops a new infection. So after you've covered your organisms for VAP and HAP, the second time when the patient gets infected, you have to have these organisms in mind before deciding on your therapy again for your patient, which include Stenotrophomonas, Burkholderia, Elizabeth Kingia, and Achromobacter. But then again, treating them would depend upon the severity and the susceptibility of the drugs to these organisms. So for Stenotrophomonas, we must remember it is intrinsically resistant to carbapenems, and trimethoprim, sulfamethoxazole, minocycline, levofloxacin, and ceftriaxone. But this will again depend upon the severity and susceptibility of the Stenotrophomonas that you've isolated. So, to summarize, remember identifying the right syndrome, the right organism risk, the right class of antibiotics in the right dosage, and de escalating at the right time should be your appropriate practice. And adequate today will help you to narrow tomorrow and timely. So, to conclude about the antibiotics, define the syndrome, match the class of antibiotics, and add MRSA and anti-pseudomonal cover when there are clinical clues, or when your patient is presenting or has a higher risk of these infections. Don't have the regular ICU reflex of adding meropenem and teicoplanin for every patient. Don't do that. Build therapy from syndrome, risk, and local data. So when you start correctly, monitor the safety. Remember, you have to review renal and liver status daily. You have to review your antibiotic doses daily when the patient is on CRRT. And you have to remember, once you've started, you have to de-escalate actively. So broad start is acceptable in shock, but broad continuation without review is poor practice. Thank you.